All right, Rajkumar, am I audible?
Yes, sir. Audible.
Okay. All right. Okay. Thank you. Thanks, Rajkumar. Thank you once again for all joining in. Case contributors for regularly sending in your cases. So without, I think we have pretty complex and interesting cases today. The chat will be open for the delegates and the panelists, and I encourage you to share your opinions and comments on the chat box. So without further ado, I'll hand it over to Avinash. Sorry, that's Avinash. If you're there, please take over.
Yes, sir. Yes, sir. So should I start?
Yeah, please.
Yeah. Okay. So this is a case of 5.5-year-old girl, second born of non-consanguineous marriage with normal birth and development. She was apparently all right till Feb 2025. And in Feb 25, she had history of cough and cold since 1 week. And then there was a rapid encephalopathy over next 4 days. She was hospitalized and they did like this MRI was done outside. She was hospitalized outside at that time. So first MRI was done. MRI, sir.
If Hiren is there, I can.
Yeah, Hiren sir was going to discuss MRI.
If Hiren is not there, we can go ahead.
Yeah.
He's there. He says he
All
can't
right.
speak. He says he can't.
Rajkumar, can you make Hiren panelist, please?
Yeah, okay, sir.
So maybe I can just go ahead and let Hiren join in for the rest. Hiren, you're there? Yeah.
I joined.
Okay.
Thanks.
Yeah.
So this was the initial scan which was done in February 26, 2025, in which we can see that while the basal ganglia and the thalami, they are showing this kind of asymmetrical varying sizes lesions. And if you come at the level of brainstem also, the dorsal part of the midbrain and the periaqueductal area of the midbrain shows hyperintensity. And if you see the DWI and ADC, there was not much restricted difference. All the lesions were showing high ADC values. On the left side, there is some sort of subtle hyperintensity along the blink also. So considering the asymmetrical involvement and lesions which are centered around brainstem, thalamus, and the basal ganglia, on the top first image, you can see that there were lesions involving the left-sided caudate globus pallidus and the inferior part of the hypothalamus, which is just inferior to the caudate nucleus. So based on this location as well as the asymmetry of the lesion, we thought this looked like more of an acquired condition, and possibility of demyelination like MOG or NMO was considered first. The second possibility of some sort of viral encephalitis, that was our thought process at that time. So these are the SWI and the post-contrast T1 weighted images, in which you can see, if you carefully see the gradient images SWI, in which dorsal brainstem, dorsal midbrain at the level of inferior colliculi, they are showing SWI blooming. That suggests some sort of microhemorrhage in that location. And if you see the lesions enhancement, that is very fluffy, incomplete ring kind of and patchy areas of enhancement along the lesions. So that also was favorable towards some sort of inflammatory demyelination kind of etiology was thought of at that time. Yeah. Any others? Yeah. Avinash, continue.
Yes, sir. So considering the possibility of demyelination, CSF was done. CSF routine was normal, even CSF NMO MOG and was negative, and HSV was ruled out. She received IVIG at 2 grams per kg. Her sensorium improved over next 6 days, and she was discharged. She was at home almost for a month. There was no history of drowsiness, but she used to complain of generalized body weakness and profuse sweating. In April 25, she again had a high-grade fever spike for 1 day. Then mother started noticing squint initially in the right hand, then subsequently over next few days she developed squint in left eye also. So again she was admitted and they did her second MRI. That we'll see.
Yeah, so these are the second MRI images. The top row is the T2 are the T2 weighted axial images, and the bottom row is post contrast images. If you see the top row, you can see that the previously seen lesions they have shown significant improvement in terms of size and signal intensity. The thalamic lesions have near completely resolved with some subtle residual hyperintensity. But even the brainstem lesions, which were involving the dorsal midbrain in the pontine area, they also shows reduction, but they have not completely disappeared. And on post-contrast images, again, that patchy areas of enhancement that we can see in the basal ganglia.
So interval reduction in the follow-up stem.
Yeah.
Yeah. Okay. Avinash, go ahead.
Next slide. Yes, sir. So here again the fever panel fever profile was normal. Serum MOG and NM was done, which was negative. Serum lactate was slightly elevated, and optical examination showed bilateral medial rectus palsy. To look for the paraneoplastic causes, USG abdo was also done, which was again negative. So her genetics was sent, and she was given 5 doses of methylprednisolone, and she was discharged on high dose of oral steroid. But there was no improvement in the squint. When she presented to us, she came with the complaint of bed waiting since last 1 week, and she was not able to walk since last 3 days. So we hospitalized her, and we had done her investigation. We did her first MRI with us. That we will see.
Yeah, so these are the images at our hospital when the patient came. We did the MRI, in which you can see that now there is some sort of progression of the lesion in the left-sided inferior caudate and the hypothalamic area, and the lesions in brainstem also were showing subtle increase in signal intensity. And that SWI image was showing that hemorrhage in the dorsal inferior colliculi level. Now, since the location of the lesion was periaqueductal and they were showing some sort of minimal increase in size, we also thought that could it be some sort of mitochondrial disease which is involving brainstem and the basal ganglia region, considering that the workup for the demyelination was negative, and this time we saw that there was some sort of increase in size of the lesions. So we thought that could it be mitochondrial also, or some other metabolic conditions. Yeah, Vinesh.
Yeah. So because she presented to us with the complaint of lower limb weakness and bowel bladder symptom. Initially, we thought it might be there might be some spinal cord lesion, but MRI spine was normal. So in view of normal CSF and persistently high lactate and normal spinal cord, we thought of ruling out mitochondrial and metabolic disorders also. So we added mega doses of biotin and thiamine and mitochondrial cocktail, and other metabolic workup was also normal. And in view of dramatic response to the IVIG during the first admission and negative metabolic screen, we started her on the IVIG. But even on the IVIG, she worsened. She became encephalopathic over next 2 days, 48 hours. So we plan to start rituximab, and there was improvement in the sensorium after the first dose of rituximab. So we have that video, sir, for first video when she became improved after rituximab.
Yeah. Okay.
So
can you see?
Go on.
She has almost So she has ophthalmoplegia that we can see in bilateral eyes. But at that time, at least she was able to chew. She was feeding well. There were no other canal nerve involvements. So we repeated her MRI after a week of first rituximab. That we'll see.
Yeah, so these are the again some set of images in which now if you carefully see on the second row the flare images, you can appreciate that the lesion which was seen at the inferior caudate on the left side and the hypothalamic area, that showed some sort of partial liquefaction, like kind of necrotic lesion, and the brainstem lesions also now you can see that further increase in signal intensity was there. And you can see the lesions on the left click on the first image in the T2-weighted images.
Recording in progress.
The bottom row shows that post-contrast images. On post-contrast images, you can see that the enhancement of more of a peripheral aspect of the brainstem lesions involving the dorsal midbrain and the pontine area. So that those now the lesions are more favoring or behaving like more of a necrosis happening within the lesions. So that was the interval changes in the imaging appearance of those lesions. So at that time, I think we started thinking that could it be some sort of some severe infection which has called necrotizing kind of condition, or are we dealing with vasculitis which has called some hemorrhage within the lesions and the necrosis within the lesions, if I'm not mistaken. Yes, Avinash, go ahead.
Yeah. So next slide.
Yep.
Next slide. I'm not able to. Yeah. So after that, she developed involuntary movements of right upper limb and lower limb, like major myoclonus. She received second dose of rituximab, and she was planned for the 5 to 7 cycles of Plex. Next slide. So after 3 cycles of Plex, he developed urinary tract infection. It was treated with peptides, but the involuntary movements increased significantly from major myoclonus to coriform movement, hemisballismic movement. Movement initially only started on the right side. So in the video, you can see the movements are more on the right side of the body, right upper limb and lower limb. So because of the increased movements, so we repeated her MRI after almost 3 cycles of Plex.
Yeah, so these are again, we can see that there is further necrosis and liquefaction of that lesion which was centered around the left-sided quadrant and near the hypothalamic area. And the brainstem lesion also were persisting. And do we have post-contrast images on this? Yes, and these are the post-contrast images which were showing some faint enhancement in the left quadrant and the brainstem lesion, but they were also looking like more of a peripheral enhancement, which were looking like more of a, again, necrotizing kind of lesions.
So in meantime, her genetics came negative, but she continued to worsen. Like she started having tongue movements which were increased. She was not able to chew and swallow food. So we started her on the RT feeds. To rule out the chronic infection, we repeated her CSF, which was again normal, and all her bacterial and fungal PCRs were negative. Also, we did her extended serum and CSF autoimmune panel, which was also negative. So here you can see the tongue movements. She started having those like these kinetic tongue movements. Because of that, she couldn't eat anything. Next slide. So in serum beta-D-glucan and galactomannan was positive. So because of that, we started her on the amphotericin B, and it continued to be positive. Because of that, amphotericin was continued. But again, she started having high-grade fever spike. Urine culture showed Klebsiella, which was treated with the colistin, and her even on the colistin, she continued to have high-grade fever spike in like 105, 106 degree Fahrenheit. So a transesophageal echo was done, which showed 1.1 to 0.9 millimeter of vegetation, suggesting infective endocarditis, and she was treated on the infective endocarditis treatment as per infectious disease specialist. Her paired blood culture grown Streptococcus and Candida lusitania, and according to the sensitivity, antibiotics were changed. Repeat transesophageal echo is showing reduced size from 1.1 by 0.9 to 0.9 by 0.7 millimeter. So we repeated her MRI here.
Yeah, so this time we can see that there is decrease in size of the previously seen lesions. But in the interval time, we can see that the lesion which was centered around the left quadrant nucleus, that is showing now areas of microhemorrhages, which were not seen before. And none of the lesion was showing restricted different, as we can see that. So it was not behaving like an abscess also, because on ADC we can see all the lesions are showing high signal intensity, be it brainstem or be it the basal ganglia lesions. Next slide. And these are the post-contrast images in which, if you compare with the previous imaging, the enhancement also has has shown reduction, and the lesions have become more necrotic, and they are showing this kind of T1 central hypointensity.
Plus we have a definite cortical atrophy which is setting in, progressive cortical atrophy.
Yeah, correct.
So these are her movement, like videos of movement. Despite of improvement in the MRI, lesions on the MRI, she continued to worsen, and she had involvement of the left side also. She started having involuntary movements on the left side, and then dystonic crisis later on.
Avinash?
Yeah. So these are all her investigations. So initially, she had high WBC count, which was thought to be secondary to like steroid. She was on very high dose steroid initially. Subsequently, HB started dropping, and she received transfusion in between. CRP was high. Even procalcitonin was high. That was at the time of urinary tract infection, and here the persistently high lactate levels. Because of that, we thought it can be mitochondrial or metabolic disorder. Next slide, sir. These are two CSF that we did during the course of our admission, and both were normal. Metabolic workup was negative, and her beta D glucan is showing like decreasing trend, but the beta D glucan in between came down, and again it has increased. And her chronic infective workup was also negative. She had high CPK in between because of the dystonic crisis, which has also come down. These are two markers for the mitochondrial disorder, FGF21 and GDF15. So out of which GDF15 is elevated, and her autoimmune inflammatory workup for SLE was also negative. That also we ruled out. Last slide. And she had intermittently slight elevation of liver enzymes, and her KFT is always normal. In between, she had hypomagnesemia and hypokalemia that was treated. We did her EEGs, two EEGs before. It was showing only slowing, and she had posterior background was slightly slow for the age. But recently, we did her EEG after she started having involuntary movements on the left side of the body, and she had two subclinical seizures in that. Next slide, sir. Yeah, next slide. Yeah, these are her blood culture workup and all the PCRs. So she had Streptococcus and Candida lusitania positive in one of the paired blood culture. Next slide. These are all urinary tract infection reports, UTI. Next slide. So yes, all these reports are okay.
No, so this is not, take this slide off, Avinash.
Okay.
So basically, we've got no markers which are positive. We went into a travel history to see if there was any infection that she could have caught from the local place. Nothing there. We've got a progressive movement disorder coming out of a very small lesion on the left caudate and the brainstem lesion. And while we did have a fungal for some time, whether that was post-rituximab, because it came after the rituximab, so whether it was an acquired secondary infection and not a primary infection, that's questionable. But the lesions have been persistently in the same place, improved with whatever treatment we've given, but clinically she keeps deteriorating. Would love to hear what others think. Yes, IL-6 has been done. It was normal. EEG done twice, thrice has been normal, except for the last time when we had two subclinical events. Creutzfeldt Jacob, I haven't really thought of. Young girl of 5 years old. Fungal encephalitis was one of our differentials, but then why am I deteriorating in spite of my improvement? Guillain-Barré, we thought of it in the beginning phase when she came with inability to walk and bladder bowel control, but her nerve conductions and MRI spine with contrast were absolutely normal. Nihaal, any feedback?
It looks more like an acquired cause, at least on imaging. I was wondering if whether it fits into a necrotizing encephalitis. Though the thalamic lesions are not seen, but it can still be seen in the brainstem, especially the RA and BP2 mutation ones. But I think genome has come in negative. So
Genetics has come negative for immune, for metabolic, as
Yeah.
well as for all these. Yeah.
but it looks more inflammatory than mitochondrial or genetic disorder.
I agree. We thought of demyelinating first, and she was
Yeah.
treated. But in spite of treatment, she kept going down. We've sort of hit her with everything we can from demyelinating. I don't know whether that's what's cleaned the MRI out, but I can't understand this progressive movement disorder over, I mean, for such a small lesion. Let me see what Guillain fungal. EEG, we've said. Dog bite history, no dog bite. Measles and measles was negative. Movement disorder do not correlate prominently. Chorea with cortical atrophy. SSP negative, ruled out at least then. It doesn't look like an ANEC.
I had a question, Nihaal.
Yeah.
I mean,
But
I know
actually
I've already spoken to a writer on this. Sorry.
the ANEC ones we have seen without thalamic changes and brainstem involvement, especially those ones which are genetic ones. We have cases without thalamic changes. So whether these are necrosis changes and fitting into ANEC or not, I wouldn't completely rule that out. Though.
Anyway,
Okay.
I had a question. I mean, I discussed with a writer. I have seen this case also.
Yeah.
I mean, the hemorrhages, is it possible the isolated CNS HLH?
Common being common, it could have been more of a cerebellar involvement. But yeah.
No, I agree. But is
Yeah.
that posterior fossa, posterior
Yeah.
midbrain is involved?
But we've done the whole HLH
Because the
workup.
hemorrhage, no, isolated CNS HLH, the systemic stuff will come normal. But because the hemorrhages which cannot be explained, the hemorrhages, some of them are in the temporal lobe also, and other areas, micro hemorrhages, which are not explained by there are no lesions over there. Am I right, Hire?
Sir, no. The hemorrhages are there where the lesions are there.
No, they're also in the cortex. No, just see.
Where in the cortex? Like
No, go to the one. There's one SWI which we had seen that day. I don't know.
no. So as far as like all the images what we have gone.
Go back.
Yeah.
I remember we saw it on that meeting. Remember, Anita?
There are no particular hemorrhage. The hemorrhage is
The
in the
micro hemorrhages.
brainstem, as in
the
the
brainstem
caudate,
and the caudate, yeah.
caudate nucleus.
At least the images which I have.
But HLH, as you know, would have improved to some. Familial HLH is ruled out on genetics.
Yeah.
I mean, it's not done once. It's been done multiple times now. She's been with us since May. We are looking at 2 months almost. And we've repeated most of these tests repeatedly to see if they change. And I don't know.
The other thought was lesions with microhemorrhages, so vasculitis involving brainstem.
Yeah, that's what I'm saying. Vasculitis, HLH, all those things come with.
Yeah.
No.
I wanted to ask Nihaal. Nihaal, you were talking about the brainstem with ANEC. So in that, lesions were symmetrical or asymmetrical?
Yeah, symmetrical.
No, so in our case, like if you see carefully.
No, I mean the necrosis.
So necrosis in our cases, like most of the lesions are showing more towards left side. So the necrosis is also asymmetrical.
No, in the brainstem is what I'm telling. The one in the inferior colliculus. But the other changes in the supratentorium were asymmetrical. And extra thalamic. I mean, not in one in the thalamus. But they were more predominantly, the extra thalamic lesions are more predominantly genetic, at least imaging wise. Not always, but not the typical bithalamic lesion which you see in ANEC.
So
but that would have been picked up on genetics. Yeah.
No, but it depends on what you ask for. No?
Yeah.
No, but we've given the history because we've done the genetics also twice, honestly. The first genetics was sent out from demyelinating first time. Then when it came back to us, we repeated the genetics and now we've sent it again for review. We asked for autoimmune, from demyelinating, from repeated infections, non-specific infection with precipitating things, mitochondrial and the full metabolic thing. So from here, no, there are no nail changes which are there. We thought of muscle biopsy. We thought of brain biopsy at one time. But then she became infected with infective endocarditis. So we are waiting to clean that out before we think. But now there's nothing much on the brain to even biopsy anymore. Muscle biopsy, we've sort of deferred it at the moment because mitochondrial seems little less on the cards. Multifocal fulminant course atrophy, take its course. Bechet's and history of oral ulcers. No history of oral ulcers. No, not done HLA typing. Any other thoughts?
At least the pattern of involvement can be seen basics. So yeah, as you mentioned, orals are not seen.
Melioidosis, didn't. Okay, we'll see what else can be. Please, if anyone else has any ideas, please put it on the chat.
Yeah.
And we can see if we can expand our spectrum of investigations. Diffuse glioma, you think it's settled because of all the immune suppression?
No, it's not glioma. I mean,
Yeah.
it doesn't look like glioma. It's only an inflammatory cause with hemorrhages and necrosis. Less likely genetic, I mean, mitochondrial. But which one is causing it is uncertain.
Maybe you could do that CSF interleukins and see if
Yeah.
that thing is.
But the problem, my infectious disease said, now that I've retuxed her, all my parameters are going to be changed.
Not the interleukins, would it?
I think it would, nah? Not the 1 and 6 and this, but the whole B cell line will get affected. Let's see. I'll find out and see. We could think of that. Let's see.
I don't know. I saw that. I remember seeing that so clearly. Those hemorrhages elsewhere. I'm just wondering why it's not seen now. Because the same presentation was shown. Understand.
I'll see, so I'll get back. I'm not remembering.
Yeah, have a look. Yeah. I
Yeah,
think you go ahead now.
Thank you.
All
Thank
right.
you.
Thank you.
Thanks.
Thank you all.
All right. If Dr. Shiji or Dr. Ruchi are there.
Yes, sir.
Yeah.
Good evening, everyone. So, this is a 9-year-old boy with uneventful perinatal period and normal development who was completely immunized with no significant family history, who came with recurrent episodes of demyelinating lesions events. His first episode was in 2021 at 5 years of age when he presented with refractory vomiting for 10 days and hiccups. On examination, his lower limb power was proximal weakness was more there than distal weakness. His DTR were depressed and cerebellar signs showed nystagmus and intention tremors were present. Serum MOG and aquaporin 4 were done, which were negative, and CSF MOG and aquaporin 4 were also negative. COVID antibodies were done, which were non-reactive.
Okay, I think again, multiple set of scans. We'll quickly go through them. This is initially scanned in February 2021. T2s are not very optimal, so let's concentrate on the flare. Basal ganglia midbrains appear to be slightly edematous, and the optic nerves also on both sides demonstrate fair hyperintensities. Cortex, I'm not sure on this sequence, these images, if they're the cingulate cortex and the frontal cortex, if the edematous or not. The posterior fossa central tegmental tracts demonstrate hyperintensities. That can be a normal variant. Anything else was mentioned, Dr. Ruchi? On
No,
the
sir.
scan? Okay, so there are some hyperintensities on the flare sequences with optic nerve changes, and I think that those are the only images we have. Okay, spine was done. Again, spine, the images are not very optimal, but it appears to be there is some long segment myelopathy, particularly more in the cervical cord, predominantly involving the central regions on the axial sections. Okay, so suspecting demyelination or post-infectious inflammatory conditions or a viral encephalitis.
It was treated as acute demyelination, and patient received IV pulse MPS for 5 days, followed by oral steroids for 12 weeks.
Okay.
Then 3 months later, on follow-up visit, his lower limb weakness had improved. This time, serum MOG and aquaporin were repeated, and serum MOG came weekly positive. And he again received steroids for total 10 weeks. And scans were repeated.
Okay, on the follow-up scan, some periventricular punctate hypertensions are seen, which was not seen clearly on the initial study. Coming down to the posterior, the deep gray nuclear structures are, in terms of signal changes, appear to be normal. Coming down to the posterior fossa, you can appreciate the dorsal brainstem again has these hyperintensities, superior cerebral peduncle on the SAT sequences, and also some areas of the vermis demonstrate flare hyperintensities. So these appear to be relatively new changes in comparison to the first study. Also in the cervicomedullary junction, you can appreciate in the dorsal pons. You have this hyperintensity out there. Dorsal medulla, sorry. Yeah. Close-up images on T280 sequences. Again, you can better appreciate the posterior fossa findings, particularly on the brainstem. There is overall generalized reduction in the volume in comparison to the first study, especially particle volume reduction. This can be secondary to the steroid medication. On the diffusion and ADC sequences, again, the central tegmental tracts in the dorsal brainstem demonstrate restricted diffusion. Plics also in the supratentorial regions also demonstrate mild areas of restricted diffusion. And coming down to the medulla, you can appreciate again areas of restricted diffusion out there. So these are likely new changes in comparison to the first scan.
Then in March 2023, at 7 years of age, he had his first relapse. He again presented with refractory vomiting and hiccups. This time serum MOG was strongly positive and aquaporin was negative. CSF MOG and aquaporin were negative and COVID antibodies were non-reactive. Patient was again pulsed with MPS for 5 days, followed by oral steroids for 6 months. Then, okay.
Yeah, another scan. So this is 2 years later, approximately 2 years later. Again, the periventricular changes appear to be stable. Maybe the left anterior periventricular is slightly new in comparison to the first one, the previous one. And the changes in the vermis are now more prominent. But if you look at the brainstem, there are also brainstem changes and appear to be there's interval reduction in comparison to the prior study. Also, the periventricular region in the fourth ventricle, you can appreciate along the dentate nucleus. There are some hyperintensities which are not clearly seen on the previous scan. So some new changes and some interval reduction, especially in the brainstem on the follow-up study. Again, diffusion and ADC sequences, you can appreciate the left anterior periventricular focus appears to be a new lesion out there. Also, the posterior fossa, especially in the midline vermis, we have these area of restricted diffusion, which was not clearly seen on the previous scan. On the spinal cord images, don't appreciate any significant changes. There may be cervical cord, there are some hyperintensities, faint hyperintensities, but yeah, other than that.
Then almost an year later, at 8 years of age, he had cushingoid features and he had difficulty in climbing stairs also, probably proximal myopathy secondary to steroids, and his steroid treatment was stopped and he was switched to azathioprine, which he took for almost 6 months. Then patient had a second relapse in July 2025 at 9 years of age, when he came with complaint of progressive difficulty in walking since last 1 year and blurring of vision since last month. Scans were done outside.
Okay. New change in the right centrum submural posteriorly. And again, if you look at the internal capsules, There are flare hyperintensities which are more prominent as compared to the prior study. Also in the midbrain, some punctate hyperintensities coming down on the medulla, you have the ventral aspect, and also along the midline cerebellum and vermis, you have these punctate hyperintensities. So at least evidently, the new change appears to be in the right post-parietal centrum semiovale and in the central white matter changes in the supratemporal brain.
After the scan, patient came to us. On examination, his vitals were stable, and head circumference was between median and +1 standard deviation. He had long eyelashes, a long chin, and coarse hair. On CNS examination, his visual acuity was 6/18 in both eyes. Restricted field of vision in confrontation test. Bilateral pupil were equal and reactive. Direct and consensual light reflex were present. His colored vision was impaired. Mainly blue and red color, he had difficulty in identifying. This time he had lower limb weakness. Distal weakness was more than proximal weakness was present. And on cerebellum, nystagmus was present and intention tremors were still present. So we did CSF. CSF showed sugars of 62. 6 cells were present. Mild elevated proteins of 43. CSF lactate was elevated, 3 millimoles per liter, and CSF pyruvate came normal. Serum ammonia was increased to 47 microgram per deciliter. Lactate was normal. CPK was elevated to 49. ANA immunofluorescence came positive, and ANA blot showed anti-MI2 and anti-KU antibodies. Serum MOG came positive. NMO and OCBs came negative. We did VEP, which showed bilaterally prolonged P100 latency. We gave MPS for 5 days to the patient, followed by oral steroids for 4 weeks, and we also give rituximab 1 dose. And we repeated MRI.
Okay. I think I'll straight away go on to the. Okay, all right. The flare sequence again. We'll look at the flares. Again, you have central white matter changes in the internal capsules, the posterior periventricular white matter. The midbrain appears to be slightly more hazy on the flare sequences, and again, you have these dentate nucleus changes, which is more prominent compared to the prior study. Supratentorially, the right parietal lesion demonstrates complete resolution in comparison to the first scan. Some anterior periventricular cystic changes are demonstrated, and yeah, these are the main changes on the follow-up study. So some posterior foci, especially the dentate nucleus, appears to be the changes appear to be more in comparison to the first scan. Post contrast, no enhancement of the parenchymal changes. I don't have an optic nerve cut to see if there's any optic neuritis at that point of time. And on the spinal cord, a single image, don't appear to show any lesions, any enhancing lesions out there. Yeah, similarly, the entire spinal cord, there's no enhancement. So just to put it into context, this is the scans from 2021 to 2023. You can appreciate there is some interval reduction progression in terms of lesions, especially if you look at the 21 and 23 scans. The vermis and the dentate nucleus has new lesions. Coming down to 25, you have the more central white matter, the posterior metal capsule demonstrating new changes, the midbrain, and also the interval follow-ups. The last study, you have again new changes in the dentate nucleus and dorsal brainstem. So I think, yeah, the main question here was that yeah, go ahead. If this fits into, yeah, sorry.
So we wanted to ask, like, since OCBs have come negative, so should we still consider multiple sclerosis as a possibility here in this case? Hello.
Yeah, Richie, got it. So the question is, you have multiphasic pattern, multiple relapsing demyelinating conditions, and I think NMO spectrum, I think you got negative. So the main condition, the criteria was, is it multiphasic demyelination, or does it fit into the criteria of pediatric onset multiple sclerosis?
I mean, it looks like a NMO spectrum disorder, doesn't it? And you have MOG antibodies can come positive in NMO spectrum disorder. And now, if you have a MOG positive, now this needs to be confirmed with a good lab, unless this MOG antibody is wrong or something. But if you have a good lab and you have titers, which is now available in India, if it is clearly positive, then almost excludes, less than 2-3% multiple sclerosis.
Yeah.
Unlikely. Only thing is, how common is this dentate nucleus found in MOGAD?
It can be seen out of Rodani. I mean, here it looks slightly asymmetrical, but yeah, I wouldn't say it's not a common finding.
Yeah.
And the optic neuritis was initially bilateral, so that was again one more point against MS, I guess. At least the VEPs were a prolonged.
The only thing is, this cystic changes periventricular. This is unusual in MOG because they usually recover, they completely recover. And
Yeah.
but there are some cystic changes, right?
Yeah, there are anterior periventricular regions.
I mean, it's a little atypical, but I still think it's that one.
Yeah, sorry, I'm unable to see the chat. Anas, if you can just point out anything, any specific questions or queries.
Sir, any dentate is what was in the asked, and any high ammonia or lactate.
Petrucci, any?
So patient's ammonia level were high, lactate level were normal.
Okay.
Even in CSF it came normal only. And
I had one question, like this corpus callosum, was the inferior blade involved as well, some hyperintendence?
Corpus callosum. Let's see. Don't have a SAG, but doesn't appear to. If you
In one
look
sagittal.
Yeah, look at the SAG here. It appears to be. It's fine. Yeah, I wouldn't call it up. Anything else, Anas?
Sir, and reason for this distal weakness, distal foot weakness?
Well, I've done a nerve conduction.
so we have not done nerve conduction studies till now.
So is the distal weakness a kind of a low motor neuron thing, or what is it?
A lower motor neuron lesion only. DTR are still depressed. There have been case reports of distal neuropathy in multiple sclerosis as well as MOG.
MOG is not so much a neuropathy as maybe a radiculopathy. So maybe that's possible. It has been described, but it's unusual. So you mean it's a diffuse neuropathy or it's like only a foot drop or something?
Diffuse neuropathy, sir.
It's very odd. Huh?
Patient is still admitted with us. We'll do NCV and further studies in patient.
Because the child initially had some proximal myopathy and then later distal. Can it be like a
proximal muscle weakness? But that could have been because of the steroid going on for so long. I mean, that's really a very long time you receive steroids. No?
4 years on and off.
Yeah.
We'll go ahead with MOG and doesn't fit into an MS, but yeah, relapsing demyelinating condition is the most likely cause. Will see any other questions? Yeah,
rituximab works both in MS and MOGAD is what Dr. Sridhar has mentioned.
Okay, sir.
Yep. Okay. All right. If there are no other comments, we'll go on with our next case. Vasit, over to you.
Yes, sir. So it's a 9 years old boy with normal this perinatal period normal development, and no, sir. I think this has been
This is not your case.
no. It's the same
Okay.
case, sir. You showed the same case.
Acha, sorry, my mistake. Yeah, go ahead. If you just know the brief history.
Yes, sir. So basically, we had this child who present us 15 days into the illness. So initially, he had presented to some peripheral center as a history of he had headache and vomiting and fever, low grade fever for around 2 days. So after second day afterwards, he had this decreased this activity in the form of not encephalopathic, but he has decreased activity. So progressively over a period of 3-4 days, his sensorium dipped in the sense that he had become more lethargic and he was not responding well to the commands. So within 1 week into they had initially not admitted him. So within around after 6 days into the illness, fever had settled within 2 days only. But after 6 days into the illness, he had one episode of query seizures. So from the description, it looked like a GTCS seizure. So after 6 days into the illness, they got him admitted because of this seizure. So at the time of seizure, they found out that he had severe hyponatremia. His sodium was 110. So this was around 1 week into the illness. Severe hyponatremia, sodium of 110. So they got him admitted, and for that they were evaluating him. They did an MRI. So can you show the first MRI? This was done exactly one week into the illness.
Okay. So these are the only, these are on top. You can appreciate the flare sequences. Nothing in the parenchyma. Also in the diffusion, we have no abnormalities. The midline SAG sequence, you can appreciate there is a pituitary abnormality out there. The pituitary gland is enlarged. There appears to be a hypointense cystic change around the posterior aspect of the pituitary gland, which corresponds with the T2 hyperintensity on the coronal sequences. The posterior pituitary bright spot is not visualized, at least on these sequences. You have the post contrast at the end, and you have some peripheral enhancement and some punctate internal enhancement, but predominantly peripheral enhancement. Unfortunately, I don't have a SAG contrast sequence to look at the stock. But yeah, these are the main findings on the first scan. And with that, hopefully this is okay, Basit.
So based on this MRI, they had this mentioned this as a case of pituitary macroadenoma. So for this, he was referred to us around. This is roughly 1 week into the illness. So here we this found out that he had this sodium. He had 110, and within around 24 hours only, the sodium had been this rapid correction was given, and sodium had gone up to 125. So here we, sir, can you share this next slide was there of examination? I don't know if you have put that or not.
No, I want to slide.
Achha. So on examination here, when he presented to us, he was drowsy. He was intermittently obeying commands, but he had some this mostly keeping his eyes closed, but he had some pyramidal as well as extrapyramidal signs. He was bradykinetic. He was obeying commands, but he seemed to be bradykinetic. Some Parkinsonian features were there, as well as he had some upper motor neuron signs also. So we suspected maybe this is due to this, maybe some sort of central pontine myelinolysis because of this rapid correction. We suspected that, but the primary issue that they had reported is pituitary macroadenoma. So based on that, we repeated an MRI just to confirm the findings. So can you show the second MRI?
No, we also thought that there was a sudden, because of the acute process, obviously there was an adrenal insufficiency. So it was either
Yes, sir.
apoplexy or it was some sort of hypophysitis.
Yes, so basically
Yeah.
apoplexy, because of this severe hyponatremia.
So I think around 4 to 5 days later,
This is
we
4
have
to 5 days later, yes, sir.
Follow-up scan. You have again new changes, new diffusion changes in the basal ganglia and also the capsular white matter. Also some findings in the pons. I think you have some areas of diffusion abnormalities. So these changes were not seen on the first scan, and also the corticospinal tracts. If you look at the sedum seminal and the perioral regions, again has these diffusion hyperintensities out there. Better appreciation of T2 sequences. The dorsal striatal abnormalities are seen here, which are not seen on the initial scan. And these are the pre-contrast on top and the post-contrast on the bottom. So you can appreciate that there is interval reduction in the size of the pituitary gland, and possibly new hemorrhagic changes out there. The cystis still remains, demonstrates peripheral enhancement. There is also enhancement of the stalk. You can appreciate it's thickened. So no, there was no surgery, just to point that out. So only around 4 to 5 days of medication, and these are the interval changes in the pituitary gland. So the question here I think we had was firstly, is it what is the nature of the region of the pituitary gland, macroadenoma or hypophysitis, and the central parenchymal changes, do they conform to osmotic demyelination? Is that right, Basit?
Yes, so main question was, this is really a macroadenoma. This is primary or which hypophysitis basically that has led to all his this apoplexy like kind of findings, and that has led to secondary changes of extrapontine myelolysis. So we did all the hormonal profiles. Sir, can you show that slide? So we did all the hormonal profile just to see that the hormones. So they were basically on the lower. Initially, they had done this 36 that was done outside. So 3rd of July that we did at our place. The hormonal profile, they were on the lower side, but they had already given steroids, 1 dose there, and after that they had repeated cortisol. So that was showing to be high. So to find the cause of this hypophysitis, we this autoimmune workup, we did infective workup, everything came out to be negative so far. We also did for his this encephalopathy, want to look, so this EEG also showed stage 2 and stage 3. So basically it was hypersomnolence secondary to query hypophysitis only. So autoimmune workup, ANA, ACE levels, anti this and IgG4, it's secondary to, it can be secondary to IgG4, that's also came to be negative. HCG, AFP, everything was normal. So basically no cause was found out, and his CSF findings showed sugar of 51, protein of 20, and cells were 9, so mostly lymphocytic. That was CSF was already done there, and after that they had given 1 dose of steroids.
So essentially, you think it's a macroadenoma with infarct, hemorrhagic infarct, or is it a hypophysitis? That's the question. I mean, because hypophysitis, with the posterior pituitary hypersignal gone, that's really unusual in a pituitary adenoma, isn't it?
Yeah, the larger ones maybe, but yeah, more commonly seen in hypophysitis, and the intervals can be. I mean, I wouldn't expect a microadenoma to be reduced significantly.
Yeah,
They
but
usually,
that actually some people, we asked the neurosurgeons, they said that they do that. Now, is the sella enlarged?
Sella is enlarged, yeah.
So why is the sella enlarged if it is hypophysitis? That's the only problem.
Yeah, Nihaal, can I please say something?
Yeah, please.
Yeah, so if on this image, if you see the third image, the axial, I don't know if it's an SWI or a flare axial, there seems to be a definite fluid level in the sella. So that more suggests that
that's a T2, yeah.
the third image on this, it's not T2, it's flare, I think.
Third image is a contrast.
No, third image
No.
where? Third image where? In the bottom?
From top row.
It's a flare image.
Ah,
Yeah,
flare.
and if you see, there's a fluid level.
Yeah, fluid is there, yes.
Yeah, so that suggests that there's been a hemorrhage.
Yeah, like an apoplexy kind of thing.
Yeah, apoplexy, and therefore the size of the pituitary we really cannot comment upon because it would spuriously increase in the setting of hemorrhage.
Oh, I see. Okay. That makes sense.
That is, I think, the diagnostic image is that fluid level, which is probably a blood fluid level.
Yeah, so here also you can see on the top, there's a fluid level on the, touching the sella. And on top of that is hemorrhage. Got it.
Okay.
But you would agree that hypophysitis is more likely than macroadenoma, or?
Yeah, hypophysitis with apoplexy, I don't know, I've not seen.
That also.
So there's a necrotizing hypophysitis, which is an unusual, very unusual type of.
Is it more commonly seen in adults than in pediatrics?
In the necrotizing variety, which is less than 1%, we read up about this all, and it seems to be seen in kids as well. And in fact, it's seen more in males than in females. Otherwise, usually hypophysitis is seen more in females than in males. But in young adolescent boys, you see it, I think out of 6 or 8 cases, there are 2 or 3 described in boys. Okay.
So hypophysitis with fluid levels, apoplexy, and causing secondary parenchymal changes on the follow-up scan,
Yeah.
correlating with osmotic demyelination.
Okay, thanks.
All right. Anas, anything in the chat? Sorry.
Is it adenoma? That is the question. I think already discussed.
Yeah.
Sickle cell ruled out is another question posed by Dr. Sridhar sir.
No, not done yet.
Okay. We'll go on to our next case then. Dr. Shika or Apuro, if you're there, please go ahead.
Good evening, everyone. So we have a 13-year-old premorbidly well child who woke up on 12th of July around 6 a.m. and had tingling sensation on the left side of his body. He tried to lift his left hand and he could not lift it, and he was not able to lift his left leg also. He tried to get up from the bed, and while getting up the bed, he could not bear weight on his left leg and had a fall. He also noticed that he could not pass urine and he could not defecate. He could not even sense the bladder fullness. But his sensorium was normal throughout. There is no history of seizures, no history suggestive of any other focal neurological deficit. There is no back pain. There is no history of trauma to the back. His symptoms remained same when he presented to our emergency at 12 hours. He was on examination. He was conscious, cooperative, well oriented to time, place, and person. There were on examination. There were no involvement of any cranial nerves. On motor examination, we noticed that the tone was reduced on the left side. There was flaccidity, and but the power also it was significantly reduced. He was much weaker on the left side when compared to the right. The reflexes on left side, the and abdominal reflex was also absent on the left side only. Right side, the reflexes were present. However, plantars were absent on both the sides. There was on sensory system examination, his vibration sense, joint position sense, and touch was normal on both the sides in all the dermatomes, and the pinprick sensation also he could appreciate with equal intensity. There were no meningeal cerebellar signs, and his spine and skull was normal. With this, we kept our syndromic diagnosis as acute non-progressive myelopathy and non-compressive etiology being higher on cards. His investigation, routine hematological and metabolic profile was normal. In CSF studies, there was 3 cells, and sugar was 70.2 milligram per deciliter, and protein was 24.2 milligram per deciliter. They were all normal. During his 5 days of hospital course, he has received some steroids in emergency, and with this there is some improvement.
Okay.
However, the return of bowel bladder sensation is now imaging.
So sudden onset changes with no preceding infection, febrile illness, and the clinical examination as you have pointed out. This slide on there. Yeah, so these are the investigations done. So suspecting non-compressive myelopathy, demyelination versus a spinal cord infarct. We have the axial T27 flares. There is mild reduction in the volume of the cortical volume, but no focal lesions in the brain. Midline sage, again, nothing standing out in the corpus callosum brainstem or the vermis. So no significant parenchymal changes, especially in terms of focal abnormalities. So this is the spinal cord, and you can appreciate there is myelopathy predominantly involving the cervical cord and predominantly involving the anterior horns out there on the axial sections on the bottom image towards the left. So these do not demonstrate any significant enhancement on post-contrast study. You can appreciate the entire spine. There's no contrast enhancement. Predominant changes are in the cervical region and predominantly involving the anterior horn cells. So as they have pointed out, these were the differences thought of. And if you look at myelopathy, the patterns are based on imaging. I think R fits into the first pattern out here. This predominantly anterior ventral cord involvement. the most typical examples are viral, especially enterovirus, and spinal cord infarction. Doesn't fit into a particular demyelinating spectrum. So the differentials out there are in the first panel, and I think infarction is the more likely diagnosis than compared to the infective etiology.
Dr. Nihaal, Sridhar, here this in the cord also the fourth nucleus pulposa seems to be of low signal. That means that might have herniated. If you see the nucleus pulposa signal, the between
like a
that might have
fibrocartilage
herniated. Yeah, fibrocartilage. That might have caused infarct to spread. Most likely, he might have somersaulted or weight, some weight bearing might have been done, which was unaccustomed. Usually, we get this history on retrospect after seeing the cord imaging. So that needs to be ruled out. But yeah, this is a this is a most likely an NTS spinal artery infarct. But yeah, fibrocartilage embolism is it.
Only point which we noted is that he improved within, I mean, quite a significant improvement within 5-6 days of onset of illness. So that was like infarcts.
Even in NTS spinal artery infarcts, people have tried steroids and they have shown some decrease because of decrease in edema. They have shown improvement.
No, infarcts. Or does it the anterior horn cell in the upper limbs? Is this involving in the upper limbs at all? The small muscles of the hand or anything of that sort?
Yeah, the hand grip was weak.
Yeah, that
only in left side, predominantly left side.
Yes, it does. The only thing is, isn't it true that you may get a little change in the discs intensity during an anterior spinal artery infarct? I mean, is that without?
If it is caused by fibrocartilage embolism, yes. As Sridhar
is it always a fibrocartilage embolism?
No, it's not always. It's one of the. It's one of the causes, but anterior spinal fluid, yeah.
Because you don't see there is no bulge over there.
No, there's no bulge. There is, but not very significant, I say. So at least over here, I think, the signal intensity is reduced and could be a possible cause, disc embolism causing ASA infarct. Anish, any inputs, intervention-wise, any further imaging?
Firstly, I don't think anterior spinal artery infarct recovers so quickly. Whatever I've seen, it's quite
actually that was
the deficit is very severe. Because this is C2, C3, C4 level, any diaphragmatic involvement, phrenic nerve, respiratory, intubation, nothing.
No. And he is improving actually within a week. Yeah.
Okay, that's very atypical clinically of an ASA infarct. The imaging is very characteristic, and we don't have diffusion, but
we don't have diffusion.
Yeah, but the clinical profile, all the ASA infarcts I have seen have dense deficits and very slow, if at all, recovery. I don't think there's any role for any vascular imaging. Even if there's an ASA infarct, we don't see any flow voids. There's no evidence of any vascular malformation. So vascular imaging will really not be of any benefit.
Yeah, thanks, Anish. The only thing was the clinical recovery.
Infective myelopathy, dengue or something.
Cell counts and all was normal. We have not, we have sent biofire report is awaited, but for enterovirus, thinking about enterovirus and all. But the improvement is quite significant, like demyelinating diseases. So we were,
The only thing enterovirus and spinal cord, those are the main ones. Unless
I have recorded the screen from our radio department they have given some sections of diffusion images. Should I share? I have put them in a PPT.
Okay, maybe we can just share it in the group later on. Maybe was any positive changes over there? As I mentioned,
They
distributed diffusion.
told that they have compared ROIs, and in that they have seen some restriction, diffusion restriction.
Okay. Those are more commonly seen in the infarcts again, ischemia or related changes.
Okay, thank you.
So imaging wise, we're thinking ischemia, Dr. Chika, as a primary possibility with enterovirus and as a secondary possibility. Only thing was the clinical recovery was lowered for an infarct.
Yeah. Oh, thank you so much.
Yeah, just let us know if anything comes up on the biofire.
Yeah, okay, sure.
Thank you.
Thank you.
All right, Razi, over to you.
Good evening. So this is a 5.5-year-old boy presented with history of fever for 1 week, and day 3 of fever, child had multiple one episode of seizure, and day 4 3 to 4 episodes of seizures in clusters, and dull activity and drowsiness post that. And the history of dog bite was there 25 days prior to this illness. Only category 2 bite over the left thumb was there without any associated bleeding. He received immediate vaccination. 4 doses was given, but immunoglobulin was not received. Birth history was uneventful, but on examination, child was drowsy with GCS of E2, V3, and 4. Child was obeying command, and pupils were bilaterally equally reactive with spastic quadriparesis, and DTRs were elicitable. So initial thought was acute febrile encephalopathy with history of dog bite, infective viral, possibly rabies, or post-infectious inflammatory encephalitis.
Okay, I think we have 3 sets of scans. First one is not very optimal, but you can appreciate, hopefully you can appreciate, at least on the T2 weighted images, there is edematous changes in the basal ganglia, also involving the capsular white matter, the brainstem, especially the midbrain, dorsal aspect of the pons. Yeah, cortex, if you see, the last image on the flares, you can appreciate some critical hyperintensity in the superficial frontal lobes. But the predominant changes are in the deep brain nuclei, basal ganglia, brainstem, with some cortical edematous changes on the initial scan. Post contrast, I think none of them demonstrate any enhancement. There was no optic nerve enhancement or optic pathway enhancement also. No meningeal enhancement, abnormal meningeal enhancement. With that, yeah, Razi.
Initial CSF analysis was showing 120 cells with lymphocytic predominance of 95% and glucose of 65 and proteins of 73, mildly elevated, and CSF meningitic panel was negative. Initially was managed in the outside hospital till here, and again they got at Rainbow Vizag. So on day 3 of admission, child had worsening encephalopathy and abnormal breathing pattern, for which requiring intubation mechanical ventilation required for 7 days. Then child was extubated. During this time, since the day of admission, child had severe autonomic dysfunction, predominantly hypertension, requiring nitroglycerin infusion, and followed by 3 oral antihypertensive medications as well. But there was no bradycardia or tachycardia. Only thing was hypertension was persistent, for which renal Doppler was done and Pudico was done, which were normal. And initial labs, calcium, magnesium, and CVP, CRPs were normal, and ESR was ESR was elevated, 60. RFTs, LFTs were normal, and initial infective workup was negative. In view of demyelinating as well, NMO MOG was sent, which was negative, and CSF autoimmune panel was sent. Still, report is awaited. Repeat CSF analysis was done, which showed decrease in cell count from 120 to 60 with neutrophilic predominance of neutrophilic percentage of 40% and lymphocyte of 60%. And proteins from 74 came down to 54, and glucose was normal. CSF cultures were sterile. Gene expert was negative. In view of suspected rabies encephalitis, CSF PCRs were sent for rabies, which were negative. And CSF and paired serum samples were sent, which showed titers of 256 and 1024 respectively, which was sent to NIMHANS. And post 1 week later, again CSF was repeated with to see the raising titers. So repeat titers were showing twofold increase in CSF as well as serum respectively. And from Nihaal, they said to repeat one more CSF to confirm if at least a fourfold rise in the titers to confirm the rabies. So still the report is awaited. Repeat MRI and spine was also done.
We will go on to the most recent MRI. Yeah, so this is the most recent one, and now you can appreciate the cortical edematous changes, especially in the frontal lobe, some degree of involvement in the parietal and the left temporal lobes. Deep brain nuclei changes, so slightly asymmetrical, more on the left. You have capsular white matter changes, again edematous changes involving the brainstem, and also the cerebellum, the dentate nuclei also slightly hyperintense for age. And if you look at the SAD sequences, especially the cervical cord, you can appreciate that is also edematous. Hypothalamic change region also is demonstrating some areas of edema along the anterior commissure. Spinal cord was done at this time, and you can appreciate long segment myelopathy. In the cervical region, it was more of a holocord involvement. There was some involvement of the central region in the thoracic cord. But again, predominant changes involving the almost the entire cross section of the spinal cord, especially in the cervical and upper thoracic cord. So the main queries were, does this fit into acute febrile encephalopathy with seizures? Any changes of hypertension or breast-like changes, or does it fit into a rabies illness? And demyelination or other clinical possibilities presented. Anything else, Razi, to add?
Child receive IVMP methylpred pulse dose followed by tapering schedule, as well as IVIG was given despite persistent encephalopathy was there. Not much of clinical improvement was seen in the sensorium despite immunomodulation.
But the imaging at least fits into a rabies kind of infection. You have predominant diencephalic, mesencephalic involvement and holocord involvement of the spinal cord. So we thought as at least imaging-wise possibility of post-rabies illness.
You think it's post-rabies or you think it's rabies?
Sorry, rabies.
Yeah, it looks like rabies.
Rabies, yeah.
Yeah, Nihaal,
we have seen about 6 cases now who live on for months to years. And one of them we actually followed up for several years, and he had actually ongoing changes in the brain. We published that in Journal of Virology many years ago, but this is definitely rabies.
yeah, so even we've had a case, sir was saying, who we've imaged over a course of 1 year, and we've also published that. I'll share it on the group. And I think specifically caudate involvement again points towards rabies. Caudate and long segment cord involvement.
Long segment cord. And holocord. Yeah, it's more of a holocord involvement.
Yeah.
And
among the basal ganglia, caudate involvement, I think, is quite suspicious of rabies.
And the problem is that all these patients who survived basically had been given rabies vaccination, but not the immunoglobulin locally. And I think that's the reason you get this partial immunity. And then sometimes, it just maintains this low-grade chronic encephalitis kind of thing with rabies. Bad thing.
It was a dog bite and a cat bite. No? Okay, only dog bite. Cat also, dog and cat. Okay.
Sir, category 2 dog bite.
Okay, category 2, sorry. Okay. So we agree, Asi, that rabies is a positive for the imaging changes. Dr. Reddy, does this have to be 4-fold increase or 2-fold?
Well, 1 week is a bit short. No?
Yeah.
And the problem is when you give methylprednisolone, you might suppress the antibody response a bit.
But I think the rising titer is usually adequate for you to presume this is a rabies. Corneal scraping?
Next step, nuchal biopsy, biopsy or something. Yeah. Nuchal skin biopsy. The PCR is very often negative because it's really RNA virus, so it doesn't.
Management wise, any other changes can we do for additional?
Just hope he doesn't survive much. Because it will be a terrible, terrible ordeal for the parents. If it is, I think it's 95% rabies. Maybe it's some other thing might come up. Hopefully not. Hopefully, I don't know. So that patient also had dorsal brain stem. First, he had spinal cord, dorsal brain stem, then caudate putamen, then he had cortex. And after about, I think he survived for 4 years. He finally had complete, and he was proven rabies at the end of 4 years as well. So it was a persistent rabies infection. And that's why it was published as a chronic kind of encephalitis.
All right, thank you. Anas, anything on the chat? All right.
People have mentioned direct fluorescent antibodies are pretty sensitive. And question about Milwaukee protocol.
We tried it in 3 patients, didn't work.
Thank you.
All right, thank you. All right, Razi, over to you.
Yeah. So this is a 13 days old boy. Initial birth history, third born, term child, LSCS, cried immediately, but meconium stain liquor was there. Initial NICU admission for 8 days. Day 1 had one episode of blood in stool as well as blood in vomiting, for which treated with fresh frozen plasma. Initial NICU stay was there for 8 days, then discharged. Day 10 of life, a child was having icterus and respiratory distress and inconsolable cry, and had episode of seizure, for which initial EEG was done outside, which showed bilateral frontal epileptiform discharges. Later referred here. On examination, vitals were stable. AF was flat, open, state-to-state variability was there. Arousable to sounds, high-level equality movements were there. Sucking and posture was flexed at upper limbs and lower limbs. Yeah, good movements were there. Morose was positive, primitive reflexes were there. Initial possibility of sepsis meningitis or any small molecule disease, IEMs, we were thinking.
So seizure only 1 episode, Razi, on day 10 and controlled by medication?
Yes, sir. Phenobarbital was given. It got controlled.
Okay. No hypoxic history, no injury, no Botas. So.
Yeah, but meconium stain liquor was there.
Okay.
Perinatal. Initial labs, septic screen was negative, and metabolic workup was normal, and TMS showed mildly decreased free carnitine and total carnitine with mildly elevated C3 levels. Urinary GCMS showed non-specific increase in a mild elevation in malic and PHPLA. Serum phenobarbital levels were mildly increased, 53, and CSF analysis showed proteins of 78, sugar of 83, and no cells. CSF culture showed no growth.
Okay, this is day 13 of life. Imaging was done. What I thought was appreciable, at least on the ADC sequences, we look on the bottom. The posterior portal capsules, the ventratal thalami, and the decussation fibers along the midbrain, and some degree on the vermis, the medulla demonstrate low signals of ADC. They can appreciate maybe in the corticospinal tracts, but the thalamus, the brainstem changes were slightly, I thought, was atypical. If you see on the diffusion also, they are slightly bright, hyperintense, especially in the internal capsule, and again the midbrain, you have the decussation fibers centrally demonstrating these hyperintense changes and corresponding those signals on the ADC. There were no areas of hemorrhage or abnormal mineralization at this point. No microhemorrhagic foci. The one on the left peritrigonal is a vascular focus. If you scroll through it, so that's not hemorrhage. No extraxillary abnormalities in terms of subdural collections or any other changes of. And on the T2s again, yeah, no cortical malformations per se, and yeah, no subdural or extensile abnormalities. Midline SAG, you can appreciate normal corpus callosum, brainstem, and vermis in terms of morphology. Yeah, so the main question was, does this fit into sepsis, or is it a possibility of a metabolic disorder? I think we thought maybe there can be changes of organic acids, especially NKH, given that the plics were involved, the decussation fibers of the midbrain were involved, or if there was any hypoxic history ventrilateral thalamus, would that be another possibility, or is it ictal related changes? But clinically, I think it did not fit. More thinking in terms of a bacterial infection or sepsis is what I was informed. So we'd like to discuss this case if there are any
Yeah,
other possibilities of lines. Yeah,
yeah. So my main question was, this child was not very encephalopathic nor very active. So this child remained in that state for almost 3-4 days. But then CSF didn't show anything. Even bloods have not revealed anything. Only point my doubt was, this child was having meconium stained liquor, then was discharged home, but only for 1 day. So can it be a residual HI changes that we are seeing on the scan? That is one question. But because we have done it on 13th day, by that time pseudonormalization usually occurs, but that level of brainstem involvement, and then can it be explained, was one thing. Eventually the child improved on its own. We didn't do much. The TMS and then urine GCMS were not conclusive as such. And one more doubt is whether the suppose if we see a hyperintense signal on the DWI, will the ADC value matter in relevance to the cytotoxic injury? Or if there is ADC signal, it has to be taken as cytotoxic only? Is there a grading? That's what I mean, over the ADC.
less than 500 ballpark, but usually it's more qualitatively. Yeah.
Sorry, it was not very clear. Can you repeat that again?
Around less than 500 is what we take, less than 500 to 400 values. But usually we usually don't measure it unless it's a tumor or.
So it is not needed as such. If there is reversal, that should be enough.
Yeah, I would say
okay, so. Okay. Yeah. So yeah, these were my questions, main questions. So can hypoxia HI changes be like this? Little, it can present like this also little later. I mean the residual part of it.
I think posterior midline capsule signal is preserved. I don't think there's any evidence of hypoxia ischemia. And Nihaal?
Sorry, posterior.
The midline capsule signal is quite preserved. So I don't think signal is preserved. So I don't think there's any evidence of hypoxia ischemia.
Oops, sorry.
Okay, what does ADC is normal for the age means? Will in this age do we see ADC like this?
Routinely, I don't see it unless there's some abnormalities in the FA values, but usually that is more demonstrated on the DWI than the ADC. So ADC abnormal is ADC abnormal, I would say.
Okay.
But child is improving, so yeah, maybe inborn error might be slightly.
Yeah, we have discharged the kid, and NKH we are not at all thinking now because the child will go downhill if it is so.
And
Only
UNGCMS also is negative, I think.
Yeah, TMS itself will tell us, but that is negative. Yeah. Okay, then we can take it as sepsis bar hypoxia then.
Yeah. Acquired cause.
Yeah. Thank you.
Anas, anything in the chat?
Any cystic lesion in splenium of corpus callosum?
No cystic lesion.
For MOCO?
Molybdenum cofactor deficiency.
Yeah, I think so for that only. Yeah.
No, there's not typical for molybdenum. There's more usually more extensive, more peripheral.
True.
So yeah. And seizure is improved after one single seizure of prenorbital. So we'll take it as a post-acquired cause. I think
Okay.
one more question here was a viral palicovirus type change, right? Or
Sorry, bilateral?
viral infection was one of the possibility.
Yeah, viral infection. My one more that was sepsis. Anyways, was the doubt, and then this hypoxia changes, these residual
Yeah.
changes, because this
Yeah.
13th ray is little atypical. That's why that is one thing.
Cooling was done. I don't
No
think
cooling
child
was done.
no cooling was done. So I think possible. Yeah. Hypothermia without hypothermia.
No, cooling was not done.
Yeah.
It was not so severe. Yeah.
So at least the viral infections is more periventricular involvement, predominance at least. So here at least the periventricular white matter, the fan shape or so that is not seen in our case. So in terms of imaging, little less likely also.
Okay, thank you.
Okay. Yeah. Anas, anything else?
That's it, sir. Any leukodystrophic?
No, this is too early. I mean, there's no change of leukodystrophy. White matter is normal. It appears to be it's a 13-year-old, 13-day-old, so that's normal for 13-year-old. Okay. All right. Okay. Thanks. Yeah, I think it's the last case, Dr. Varsha, if you're there.
Yeah. Hi. So this is a 13-year-old female patient who was previously normal and now presented with acute history of altered sensorium for the 3 days. That was on 21st of June. And this was in the form of increased lethargy, sleepiness, and decreased eye opening and decreased speech. The patient had fever for 1 day, and there was only one documented episode of about 103 degrees Fahrenheit. And after that, the patient had no fever, and she had weakness in both upper and lower limbs. There was no verbal response. Memory was intact. On examination, GCS was low. There was increased tone in the right upper and lower limb, and power was bilaterally reduced, more on the left side. Face was deviated to the left side, and plantar were flexor on both sides. Meningeal signs were absent, and bladder sensation was present. And patient investigations, DNA profile was sent, which was normal, and the rest of the investigations were awaited. And D-dimer was actually increased. Though the fibrinogen levels were normal, D-dimer was increased and platelet was normal. Homocysteine levels were also elevated in this patient, and rest of the hematological profile and metabolic profile was normal. Carotid Doppler and echo were also normal. After that, the patient was evaluated with the MRI brain. And these are the...
Yeah, sorry, go
ahead. I go or you?
Yeah, you can go ahead.
So these are the T2 weighted images, which show that there are changes in bilateral basal ganglia and also in the right posterior limb of internal capsule. So we see both cystic changes within these regions, and there are some focal hemorrhages also, which are better picked up in the GRE images. And similarly, on the flare images and on the post-contrast flare images, also there is some enhancement, which is extending into the bilateral crus cerebri. And so the clinical suspicion was that of a brainstem vasculitis, and carotid and angio was done, which was normal. There was also post-contrast flare imaging that was done, which showed some peripheral enhancement, especially on the right side. So the clinical suspicion was that of small vessel vasculitis, because the patient had presented acutely. So we were basically confused about the further investigations that need to be done in this case, and what were with the differentials.
The vessels are almost normal, right, Dr. Varsha? I mean, in the vessel wall imaging post contrast, at least the medium and long vessels are normal. Yeah, I agree that there is some microhemorrhagic foci also in the basal ganglia out there. And day of illness and scan, 3 days, 4 days after the illness. Yeah, any takers for that scan for the changes? Looks like basal ganglia changed predominantly with some hemorrhage, some necrosis also going on there, inflammation and microhemorrhagic foci in the basal ganglia.
All 4 mutation a possibility?
But 13 years, that was a little hard to say. Usually present more
Yeah, that's why I
early
asked
on.
renal function.
Febrile illness also not very severe. I mean, not very severe, only 1 day. CSF was done, Dr. Varsha, by any chance? I think we might have lost Dr. Varsha, but yeah, CSF is not predicted here. It looks like a vasculitis type of injury. Even they have a microhemorrhagic foci, the diffusion changes.
Yeah, and if you see I think the basal ganglia changes are slightly subacute to chronic because the frontal horns are slightly dilated.
Yeah.
So it's not at least the MRI findings are not very acute.
Or is it a dual stage, at least 2-stage injury?
Yeah, that's possible.
Yeah. If you look, the cystic changes along the caudate. Yeah, caudate, yes. Cystic changes are there, but the striatum and the capsule corona data has some diffusion changes. So it may not be the
and
first.
some edema is also there.
Yeah, some edema is there. So it might not be a first event. And the atrophy also is slightly unusual. I mean, cortical atrophy, cerebral atrophy.
So should we consider some demyelinating disorder as well, and something on the lines of some encephalitis, hemorrhagic encephalitis?
Yeah, in terms of descriptive terms, it is, but we need to come to a cause. Is it the only first event? I mean, first symptoms for the child? No previous history?
There was no previous history of any such complaints.
Even the frontal one is slightly prominent.
Small vessel vasculopathy.
Yeah, small vessel vasculopathy, but not a single stage. I mean, single point.
Yeah, multi-stage hit because there is some chronicity in view of the frontal horn prominence.
Yeah,
and diffusion and edema suggesting a secondary acute hit.
So then the question is, the investigation wise, do they send for genetics or?
Yeah, I think genetics.
Genetics.
Warranted.
Even
can
the
we how to call for?
Call for, yeah, but they usually present more earlier. And development. Yeah, I mean, vascular in terms of progressive vasculopathy, yes, call for is differences. Yes. Homocysteine levels also elevated. So I think.
Could I see the angio once again, please?
Yeah.
This is absolutely normal.
Yeah, it looks pretty normal. Anas, any suggestion on that?
So what type of small vessel vasculitis would be having this pattern? Like generally they're multifocal and distributed in the deep gray matter as well as in the white matter. And so what types of small vessel vasculitis would present like this?
Maybe genetic ones. I'm not very sure.
Yeah, I think the genetic testing is definitely warranted.
In chat, sir, is it mineralizing angiopathy or late onset MMA or thiamine biotin responsive basal ganglia disease with microhemorrhages?
No, biotin thiamine, I don't think they have commonly microhemorrhages. And periaquid, I mean, the thalamus is spared. DARA2 mutation, maybe any skin lesions? Which I don't think you're mentioning.
There's no skin lesions as such. We won't
Yeah,
consider
metabolic
any.
force stuff and genetics will be required.
Yeah, I think genetics has to be done. As we mentioned.
And metabolic
Yeah,
also. So metabolic also, ammonia lactate, female CPMs. It is not
Means in
run up on
genetic,
the
in
genetic
genetic.
whole exome sequencing. Whole exome sequencing.
Whole exome. Yeah.
Okay.
Because it's an acute as well as chronic thing, but the child has only one presentation. So some subclinical presentation might have occurred previously, which did not come to the hospital. When you're acute and chronic, you have to think of a neurometabolic or genetic etiology after ruling out the acquired etiology.
Right. Right. Okay. Thank you.
Okay. Thanks, Tosha. Anas, anything in the chat? Improve? Okay. If nothing, Tosha, I think we conclude that yeah, whole exome sequencing and to cover the metabolic profiles also to be done.
Right.
Maybe we can,
Thank you.
if it's done and you have an answer, please get back to us.
Sure.
Yeah. Thank you.
Thank you.
But I think yeah, that should be a last case. Sorry for the technical issues. Wasn't able to see the chat and use the mouse, but I will get that sorted out by the next session. So see you again in 2 weeks' time. And please submit your cases by 30th of July. Encourage the radiologists also to send their cases. Predominant cases are sent by the neurologists. So see you in 2 weeks' time, and have a good night and a good weekend. Rajkumar, you can end the session. Thank you.
Okay, sir, we are closing. Yeah, Friday.